This film is intended for eye surgeons for training and education purposes. Viewer discretion is strongly recommended. Hi, an elderly male patient who is this brown cataract and a thick carcass is posted for phacoemulsification. In these brown or black cataracts, the visualization is a challenge. We don't get a good background contrast for most steps of the surgery until the nucleus comes out. Once the nucleus comes out, of course, we have the red glow. Until then, it's a struggle to visualize it properly. So let us begin by staining the capsule well. Now, it does help to have a little bit of a blue contrast. Still, it's not good enough, but something is better than nothing. So stain the capsule, place the OVD into the antechamber. I'm creating the main 2.8mm posterlimbal based incision. So time to perform the rhexis. It's important for us to realize that when we are aiming to manage a very dense cataract like this, which is bulky as well, it's important to have a very large rhexis. So I'm aiming to have a rhexis which is about 5.5 to 6 millimeter in size. That is my first priority. The idea is if you have a larger rhexis, there's a lesser stress on the anticapsule and the capsule bag per se during nucleus management. And because it's going to be hard, there is going to be some amount of stress being induced during lateral separation. So having a big rhexis does help. A very gentle dissection is critical. We don't have any epinucleus or cortex, just to ensure that the nucleus is free from its attachment to the capsule bag. It's a step to rule out any corticocapsular adhesions. OVD is refilled into the antechamber. The nucleus mobility is confirmed. Time to do the phacoemulsification. Let me pause here again. As I keep mentioning, the length of the tip has been enlarged. So we have a fairly long exposed tip. This ensures that I have a better reach towards the posterior plate as I'm sculpting. This is the idea here. And the settings for sculpting would be 90% torsional, about 16 is the flow rate and 80 is the vacuum. The first trench is created. In this case, I'm just trying out to do the trenching with one hand itself. The nucleus is quite stable. I don't need to stabilize it with the second instrument. You can see that there is some amount of pushing at the nucleus, and this is not the ideal way. The nucleus is rotated, sculpting is begun. As I go to the central part, you can see that the nucleus is being pushed at. The reason is the central part is much more thicker. The ultrasound energy, whatever I'm using, is not good enough to just cut and melt the nucleus as it is moving ahead. So it's hitting a wall, and that is the reason why the nucleus was mobile. Now I've increased the power to 100%, and now you can see that the nucleus is not being pushed at so much. So that's the trick. So when we are with a denser nucleus, we need to use more power just to ensure that the tip should move in just like a hot knife through butter. Now mind you, we are using just the torsional energy here. The longitudinal part would be set to 0. At this stage, I'm just trying to refocus and see whether am I able to see the lens striations. So I'm still able to visualize the horizontal striations. So if I'm able to see the transverse lens striations, then it indicates that I need to go a little bit deeper. So I'm just going in and deepening the trench. At this point, at the central plate, you're seeing the color is much more whiter, lighter, but in the peripheral part of this groove, the color has changed. It has become much more darker. The striations are very less clearly visible, suggesting that that portion of the trench is thinned out. So I am going to redo the trenching in the central part just to thin it out. So as we go deeper, you can see there is a color change in the posterior part of the groove. So if it becomes darker, it indicates that the posterior plate has got thinner. So that is one way of validating the depth of the trench, because after some time you will not be able to visualize the transverse striations which we have been talking about. It's still not deep enough. It's not maybe 95% depth, it's about 90% depth. So I decided to go ahead and do the lateral separation maneuvers. Two instruments are placed as deep as possible in the groove, and then the lateral separation maneuver is being done. So we've got 4 pieces which have been separated. Time to refill the OVD into the antechamber to safeguard our endothelium. Now what I am using is dispersive OVD, which contains the chondroitin sulfate up against the cornea, and behind it and more posteriorly I'm going to place the HPMC. So this helps us to prevent any thermal injury to the endothelium. So when you're trying to emulsify these fragments, it's mandatory to understand that we should have as less of a turbulence as possible inside the eye. If you have got more turbulence, then the fragments are going to jump around and hit the cornea, and that is one of the main reasons for having a corneal edema in the first post-op day. So it's important to go in very slow and very gentle. My second instrument is just on top of the fragment, just to ensure that there are no stray fragments jumping around and hitting the endothelium. I'm just seeing that the fragment is dancing around the tip as the emulsification is going on, and this is the right way to do it. The second piece is now pulled out of the bag and now is being emulsified at the level of the rhexis margin. Another one interesting point I want you to observe here is that look at the exposure of the tip. Now it has been brought down to very minimal exposure, because now we don't want a very long bevel. So by keeping it short, I can ensure that the tip can be in the center part of the chamber and there is less of a wound hydration, and that ensures that I continue to see well. There's a reason why the exposed tip length has been reduced. Time to remind myself that I need to go and replenish some OVD. So it's worthwhile all this effort when you're dealing with these hard cataracts. Worthwhile to go in and replenish the OVD. Again, this is my modified soft shell technique, wherein instead of the cohesive OVD, we're using HPMC underneath the dispersive OVD. This is the last fragment to be emulsified, and again, in a very controlled manner, this is emulsified. I don't want to have any turbulence or the fragments just jumping around in the antechamber. I'm very slow with the usage of power. The power which I'm using is about 60% continuous mode with the IP on, and the bevel is turned towards my left side, and you can see that the fragment is just jumping around or dancing around the tip so that it gets reduced in size over a period of time and eventually disappears. There is one stray piece which was jumping around and eventually it is also got consumed, and this last bit of the fragment. So nucleus division was the most difficult part of the surgery in this case. Thankfully it went on well in a very controlled manner. The remaining cortex is aspirated and the time to implant the lens. The planned hydrophilic single piece lens is placed inside the bag. That's it, the case is done. So let me just check the CDE at the end of the case. It's 64.62 and it is to be expected. This is very dense cataract, and these are the first day post-op pictures. Very minimal corneal edema and the patient is happy. So the important thing to understand from this case is even though I've used a lot amount of energy, it has not resulted in the significant corneal edema on the first post-op day. These are the following reasons. The mechanical trauma because of the heating of the fragments of the endothelium is the primary reason for a corneal edema to develop in these hard cataracts. And if you can find a mechanism to minimize this by having a controlled emulsification without turbulence and at a much more posterior plane, is at the level of maybe a rhexis, then the incidence of endothelial damage would be significantly lesser, and hence we can have a clearer corneas on day 1. Number 2, the increased energy usage will not cause a damage to the endothelium provided the plane at which the energy is delivered is far away from the endothelium. In this case, we're doing sculpting using the torsional energy. You can see that the nucleus is quite far off from the endothelium. So the energy which was being delivered is quite far away from this. So that's the reason why it has got a lesser impact on the endothelium. If you consume the same amount of energy, but the majority of the energy was consumed in the antechamber, then definitely the endothelium would take a hit. So these are my thoughts. Hope you found it helpful. Thank you for watching.